If we look to see what their success has been, and this was an early evaluation, we supported them at $75,000 a year, not necessarily a lot of money for a couple of years. But they've been successful at getting grants and being supported in their own research through our National Institutes of Health, through other foundations. So by giving them this opportunity to develop their expertise, they've been able to use that and leverage that to advance the whole field of palliative care. Along with our Faculty Scholars Program, we had a wide-ranging grants program, and these grants looked at a variety of topics that, again, are being discussed here at this meeting, the whole issue of epidemiology, the extraordinary work that David Clark has done. And in fact, David Clark is writing a history of this program. We looked at the physical, the social, the spiritual, and existential components, and we gave grants in this area. We looked at the role of the arts and the humanities, and we supported some grants there. We supported some public education, clearly professional education, newer service delivery models, and then we worked very much on policy. And I'll just give you some examples of these projects. One was we had a national medical educational consensus conference, and we developed an undergraduate and graduate medical education curricula in end-of-life care. So this was something we supported that's had an enormous impact on the use and the application of curricula in the United States. We identified a significant problem in our prisons and jails, where more than 1 million Americans are currently in prison. We found that there was little care for those individuals who were dying in prison, and we supported efforts to improve this. And at the same time, we supported efforts at a community level to expand services to patients and families in grief and bereavement, and to learn better about the needs of patients and families in community who have experienced a death. And so the project on improving the care of dying in prisons and jails has been one that we partnered with the Robert Wood Johnson Foundation, and we're able to develop within our jails and prisons throughout the country, predominantly our prisons, hospice programs, where the hospice volunteers in these efforts are in fact the inmates of the prison. In the United States, if you are in prison for life, it is unlikely that you will ever be discharged as you are dying. And so one model program is in the Angola prison, where there are 5,000 inmates. There are approximately 100 deaths per year, and the hospice program within that prison has had a transforming experience. And this is a video, again, that I'd be glad to share with all of you, that allows one to see the extraordinary efforts of how introducing a hospice into a prison changes the ability of care for those prisoners. These prisoners then became identified as dying. They were pain and their psychological symptoms were managed. Their families were notified. None of this had happened before in our prison system. So it's quite an extraordinary effort that continues to exist to the present time and expand. But this is, again, uniquely American because most countries discharge their dying. In our country, we continue to keep them in jail. And this effort has now spread throughout the United States in our major prison system to suggest in a unique and incredibly marginalized and vulnerable population the ability to at least provide decent end-of-life care. At the same time, the Robert Wood Johnson Foundation supported states to create their own task forces that would focus on end-of-life care. And these were policymakers. These involved the government, the medical community, the community efforts, all who came together in these states to work on very specific projects. So this became another type of public engagement, a civil society engagement to see how states themselves could look within themselves and at themselves to see how they could improve the care of the dying. We also identified how important the arts and the humanities are in any initiative as we begin to talk about the difficulties of how we think about caring for the dying and the impact of death on a society. And so we wanted to develop and identify and convey meaning in facing illness and disability and death, and and to try to evoke and deepen our understanding of the diverse metaphors that shape the experience of suffering and dying and bereavement. And so to this end, we supported, in a medical school situation, a photojournalist who spent time with medical students as they dissected their first cadaver, because that is typically the first time a physician in training is introduced to a dead body. And this is a wonderful, wonderful photojournalist story of medical students experiencing the dissection of a cadaver and their own perspectives. And this is now used as a teaching tool in our medical schools and part of what's called our white coat ceremonies in the United States. And this is just one page from it. And this was the experience of a medical student saying, "I have finished my dissection of the wrist and hand. It is 3 p.m, and I have to pick up my daughter from school. I hold her hand tightly as we cross the street. She notices, but doesn't say anything. Her hand is soft and warm despite the January cold. This is what life feels like, I say to myself. I have learned something about the human touch. I will never hold someone's hand the same old, ignorant way again." And again, using this experience of medical students with cadavers as an experience of their first experience with death, and how that might transform their own thinking as they began to care for patients who were dying in their further years in medical school and in training. We did a series of artistic projects. One there you see the quilt, which was a very famous American artist who would go to hospitals and do sketches and then put them into this extraordinary quilt work. And these quilts have now come around the country as part of exhibits, again, being used as an artistic way of talking about Americans' construct of illness and death. We've supported a variety of dance programs and plays, again, all attempting to address these kinds of issues. Joanne Lynn, who was a member of our board for a period of time, wrote a wonderful book called The Handbook for Mortals, which was the guidance for people facing serious illness. And this is a very, very practical book that Americans could read as they were facing serious illness so they could learn about their choices. Okay. Ira Byock, again, a leading palliative care expert, wrote a book for the public called Dying Well. Again, engaging the public in stories about how we can care for each other and do well. And Marilyn Webb wrote a book again for the public on the good death and the new American search to reshape the end of life. And so these were all books that, again, engage the public in these wonderful discussions. One of our faculty scholars, Nick Christakis, wrote a book called Death Foretold, which looked at the idea of how we prognosticate about a patient's illness and how we, as physicians, come to these kinds of facts. And then Dan Tobin wrote a book on peaceful dying, again, providing this. And again, this was all part of the construct of death talk. The debate about physician-assisted suicide was clearly paralleled in 2 different books, one by Herb Hendon, talking about the Dutch experience called Seduced by Death, and then Tim Quill, an advocate for physician-assisted suicide, talking about the role of a midwife through the dying process, i.e. physicians who aid patients in dying. So we had these lively debates about these issues, which again encouraged the public